welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
So for our second presentation today, we have Holly Westerkamp. She's a PGY2 emergency medicine pharmacy resident at Duke University Hospital. And today she'll be presenting on the comparison of Clevidipine versus Nicardipine in the treatment of hypertensive urgency and emergency in our critically ill patients.
Some objectives for today. So first, we'll be starting off talking about hypertensive crisis in general and really observing the difference between hypertensive emergency and urgency and what delineates the two. Secondly, looking into some treatment considerations and understanding the difference between some medications currently available for hypertensive crisis, though there isn't one that's necessarily our current preferred first-line agent. Third, we'll really jump into the journal club we're discussing today, which is a multi-center retrospective cohort study comparing Nicardipine to Clevidipine. And lastly, we'll draw some conclusions, so identify patient situations in which Clevidipine would be an optimal antihypertensive agent. So jumping into antihypertensive crisis. So hypertensive crisis in general is an acute marked elevation in that blood pressure that may or may not be associated with signs of end organ damage. And that's where we really start to delineate between urgency and emergency. So when we're talking about the prevalence of hypertensive crisis, so about 30% of adults in America in general have hypertension, and 1 to 2% of those will have a hypertensive crisis within their lifetime. Whether or not that actually pertains to end organ dysfunction or not, though, is questionable. In America, though, due to the readily available access to antihypertensive medications such as Nicardipine and Clevidipine, there's actually been a 0.3% reduction in our mortality rate over the past 7 years from 2006 to 2013. Now, the pathophysiology of hypertensive crisis in general isn't totally well known. Two of the more common causes are going to be that medication noncompliance in those patients that present with chronic hypertension, as well as the use of sympathomimetics. But they're causing that mechanical stress on our vascular cell walls, leading to that pro-inflammatory response, causing coagulation cascade activation, fibrin clot deposition, and ultimately that hypoperfusion at our target organs. Some of the risk factors we think about for hypertensive crisis, amongst things such as inappropriate blood pressure monitoring techniques itself, can be uncontrolled comorbidities such as diabetes, hypertension, smoking, acute distress while in the hospital, so anxiety, pain, and then other clinical conditions, so like thyroid storm or pheochromocytomas. Now, when we start to delineate between emergency and urgency, so the actual definitions are really based on expert opinion. So hypertensive crisis itself will be that systolic blood pressure greater than 180 or a diastolic greater than 110. And then where we delineate between the two is that presence of new or worsening target organ damage, which we'll talk about in the next slide. If there is the presence of that target organ damage, they'll fall into that hypertensive emergency bucket, versus if it is not present, that hypertensive urgency or that asymptomatic elevated blood pressure bucket. Now we're looking at end organ dysfunction. The most prevalent hypertension-mediated organ damage will be ischemic stroke, followed then by pulmonary edema all the way down to aortic dissection, things such as like renal failure or kidney injury kind of falling somewhere in between. Other things that our patients might present with being headache, dizziness, altered mental status, or decreased urine output, may hear rales or see signs of peripheral edema on physical exam. Now, when we think about our treatment considerations for hypertensive crisis, our overall goal is to produce that closely monitored blood pressure reduction to minimize end organ dysfunction while also limiting the risk of hypoperfusion injury that can occur when we drop our blood pressure too low too fast. Now, again, all of these recommendations are largely based on expert opinion, much less on actual randomized controlled data. But the real consensus from 1984 until now in 2025 has been to reduce blood pressure by 25% within the first hour in hypertensive emergency versus within 24 hours in hypertensive urgency. Now, whether or not that's a reduction in systolic blood pressure or MAP is also up for question as well today. And again, there's no real preferred first-line therapy agent. So this all really stems from proposed pharmacokinetic and pharmacodynamic effects. So the perfect agent in our ideal world would really be a rapidly acting and easily titratable medication. However, the guidelines do recommend specific therapies based on organ systems. So you can kind of see here, we kind of play around with this quite a bit, but thinking about things such as bolus doses of betalol, all the way to our infusions of things such as nitroglycerin, nicardipine, and clevidipine. However, what we'll really be focusing on today is going to be our short-acting intravenous calcium channel blockers, or our CCBs, which selectively vasodilate that arterial system with a favorable pharmacokinetic profile. So when we're looking at clevidipine and nicardipine, the major difference between the two is going to be how fast on and off they are. So clevidipine is going to be that ultra short half-life of about 2 minutes, whereas nicardipine has that intermediate half-life of about an hour. Now, looking at some of the previous data in which we have evaluated clevidipine versus nicardipine, much of how we use these medications has been extrapolated from these pathologies where blood pressure control or tight control is necessary. And we have seen a benefit in these instances with clevidipine. So for example, in stroke, there's not really any difference found between the agents to the time to goal systolic blood pressure, but the volume burden was higher with nicardipine. So several institutions I've heard will have restrictions revolving around fluid restrictions for their use of clevidipine. And then in cardiothoracic surgery, clevidipine has been shown to increase the time and goal blood pressure range, especially when a narrow window is targeted. Now, jumping into our literature review for today. So I looked at the comparison of clevidipine versus nicardipine in the treatment of hypertensive urgency and emergency in critically ill patients, and this was published in 2024. And they aimed to evaluate the efficacy and safety of clevidipine versus nicardipine in medical ICU patients receiving treatment for hypertensive crisis outside of those stroke or cardiothoracic surgery patients that have been previously studied for these study drugs. So this was a multi-center retrospective cohort study conducted from January 1st, 2013 to February 8th of 2023, so over a 10-year period. And they included patients from 2 level 1 academic medical centers in a community-based healthcare system. And those patients they included had to be adults age 18 years or older and received the study drug for longer than 1 hour in the treatment of hypertensive crisis as defined by the practicing provider. And the infusion had to be initiated in the emergency department or upon admission to a designated critical care unit, being the medical, neuro, or cardiology critical care units. And they ended up excluding patients for which therapy was initiated for an indication other than hypertensive crisis. Patients had undergone an acute cardiothoracic surgery or experienced a hemorrhagic stroke, aortic dissection, or aneurysm. Patients were pregnant, and if they had received both study drugs within a 24-hour period. If they had received both study drugs outside of a 24-hour period, they could be included to the study. And the primary outcome they were looking here was time from infusion initiation to goal blood pressure. And this was calculated using the highest blood pressure measurement before infusion initiation to the target goal measurement. And this could either be the 25% reduction per guideline-directed therapy or an otherwise physician-directed goal. Some of the secondary outcomes they looked at was time to guideline-directed blood pressure achievement, time from order entry as designated by the order being signed in the MAR to initiation of study drugs, so the order being documented on by the nurse in the MAR, time from order entry to goal blood pressure achievement, study drug volume burden, total patient volume intake in terms of oral and IV formulations during the study drug infusion, ICU length of stay, medication cost, and then some safety outcomes, largely looking at blood pressure and heart rate excursions to see how well patients maintained their goal blood pressure range. So the study used an alpha of 0.05 to complete a 80% power, which they calculated needed 100 patients per arm, in which they would be randomized 1-to-1 on the basis of a randomly generated numbers assigned at list retrieval. So the interventions, so clevidipine would be started at an infusion rate of 1 milligram per hour and titrated by 1 to 3 milligrams per hour every 2 minutes, not to exceed 21 milligrams per hour, whereas nicardipine would be started at 2.5 milligrams an hour and titrated by 2.5 milligrams an hour every 15 minutes. And it was assumed here that the titration parameters set forward by the institution were actually followed. So they ended up screening 1,216 patients, ended up including 182 patients, over 1,000 of which were excluded, mostly due to being admitted to an excluded service, so not the medical, neuro, or cardiology ICU. And then from there, 103 patients were randomized to Nicardipine and 79 to Clevidipine. So it's important to note here that the Clevidipine group did not meet that 100 patients per arm to meet power. So looking at the baseline characteristics, overall, the patients were well balanced between the two groups. On average, they're around 60 years of age, with about 47% being female, and an average weight of around 80 kilos. Again, being relatively well balanced, a majority of the patients did have hypertension, about 80%, which we do expect that being a common risk factor for patients to present with hypertensive crisis, and about an average of 40% of patients coming in with chronic kidney disease. The only statistically significant difference between the group was that the Nicardipine group had a higher median proBNP on arrival. When we looked at the primary outcome, though, time to goal blood pressure achievement was similar between both study groups. So Clevidipine was achieved at an average of 35 minutes versus Nicardipine at 33 minutes, with a p-value of 0.37. Looking at our secondary outcomes, though, 25% reduction in blood pressure within 1 hour, p-value of 0.42. 65.8% of patients in the Clevidipine group reached goal blood pressure versus 71.8% of the Nicardipine group. Time medication it was infused was roughly around 25 hours for both medications. Time from order entry to infusion start, Clevidipine was started on average 16 minutes after order entry versus Nicardipine at about 29 minutes later. It is important to note that Nicardipine had to be pharmacy compounded. Unsure if that meant at the bedside versus tubed up from pharmacy. And then finally, time from order entry to goal blood pressure. Goal blood pressure was established with Clevidipine at around 75 minutes versus 84 minutes with Nicardipine. In terms of study drug volume, so Clevidipine accounted for less volume overall, so 222 mLs versus 518 mLs with Nicardipine. However, when we looked at the total volume received, there was roughly just over 3,000 mLs in both study groups. So whether or not we were being good stewards in terms of overall volume intake is questionable following the study drug initiation. ICU length of stay, though, was about 5.9 days for Clevidipine and 5.8 days for Nicardipine. And then percent of time in goal blood pressure range was similar between the groups as well. So fraction of time in goal blood pressure range was similar. So we're seeing that both the efficacy of time to goal blood pressure and the actual safety of both of these medications in terms of time spent within that range, so no excursions outside of that range, was similar between the two groups. So 43.1% versus 42.3%. Looking at vasopressor use, this was very infrequently observed, but more utilized in the Nicardipine group. 6.9% of Clevidipine versus 17.6% of Nicardipine. Bradycardic events, again, were not statistically different between the two groups. Here, receipt of additional IV antihypertensives, though, were different between the two groups. Patients receiving Clevidipine did require additional antihypertensives more often, so 36.7% versus 18.4%, with a p-value of 0.01. And of course, kind of as expected, the drug acquisition cost of Clevidipine cost about $199.37 per vial, which is about 682% higher than that of a bag of Nicardipine. So the authors concluded that the medical ICU patients who received Clevidipine did not achieve goal blood pressure significantly faster than those receiving Nicardipine for the treatment of hypertensive crisis. They did point out that the projected sample size was not reached in the Clevidipine group specifically. It was difficult to reach due to patients being admitted to a non-primary unit. And the risk of type 2 error, therefore, because there was no difference found, is prevalent. There was discrepancies between blood pressure goals, as I stated, so they could have gone with the guideline-directed 25% reduction in blood pressure or a physician-directed goal. They did go with the higher of the two when delegating patients in this study. And then lastly, the use of Nicardipine compounding. They did not have a commercially available product, whether or not that was compounded at bedside or tubed from pharmacy, that I'm not 100% sure of, though. Some of my own conclusions, so some key study takeaways. So the blood pressure variability and time to goal blood pressure throughout treatment was similar between groups. So therefore, the safety and efficacy of these two agents in this specific patient population are similar. The only really significant difference between the therapeutic interventions was a higher volume burden with Nicardipine, but this wasn't necessarily reflected in our total fluid burden. Also, when we look at specific patient groups, so after stratifying by specific blood pressure goals, clevidipine was still similar to nicardipine. So most stringent goals of less than 140 millimeters of mercury was reached faster in those with nicardipine. But when blood pressure goals were narrowed, i.e. there was a narrower therapeutic window, patients receiving clevidipine had fewer blood pressure excursions, showing that the safety of clevidipine may be beneficial in these patients, which I think is something we kind of see in practice today. Also, in a post-hoc analysis, looking at those hemodialysis-dependent patients, there was also similar times in goal blood pressure range, meaning that there's probably a minimal clinical benefit with that reduced volume burden of clevidipine. And lastly, clevidipine was associated with a nearly 30 times higher cost burden in hypertensive crisis. Again, this difference in cost does not seem to be offset by improvement in clinically relevant outcomes in a general hypertensive crisis patient. Some strengths of the study, it did evaluate a new patient population that we don't necessarily use clevidipine in very often. And it did have comparable timing to studies conducted in those CT surgery and stroke populations. Some limitations are just things that I would love to know more about, being the pharmacist role in these situations. In my own practice, we play a very heavy hand in patients with hypertensive crisis for specific organ systems, especially like neurologic crises. But our role can be very different in a patient presenting with hypertensive crisis with acute kidney injury. So I'd be curious to know the pharmacist's scope and role in these situations. There was also no reported dosing medians in which I could find, so I'd just be curious to know what the average dosing these patients were on. Questions of blood pressure monitoring methods, so whether or not these were largely cuff measurements or A-line measurements, and then the use of other non-antihypertensive medication confounders, so such as patients being intubated with propofol, other medications that could confound their blood pressure readings. Some next steps are things that are coming up for clevidipine. So there is a study evaluating clevidipine in patients with hypertensive emergency and sub-emergencies, as well as the CLUTCH trial, which is a phase 3 trial looking to evaluate clevidipine on the ability to reach systolic blood pressure goals in patients with intracerebral hemorrhage, which I think will also be interesting to look more at some of those goals in ICH in general. So my kind of final takeaway, clevidipine I think is still preferred in populations requiring aggressive blood pressure reduction within narrow parameters. So patients such as neurologic hypertensive emergencies. However, this cost-benefit relationship doesn't really seem to translate to hypertensive crisis overall or in general. And with that, thank you for tuning in, and I will go ahead and take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.